If you bring up the subject of cholesterol in, any casual conversation about health, the reaction is almost always the same.
Oh, completely. It's immediate. It's negative.
Exactly. It's been framed for decades as this villain, the #1 threat to your heart.
And that perspective, while you can see why it exists, is just fundamentally incomplete. We have to start by reframing this whole thing.
Okay.
Cholesterol isn't just a danger. It's an absolutely indispensable lipid for human life.
Indispensable. I think that's the key word. We're talking about something your body needs to survive. It's like the ultimate utility player.
It is.
It's a critical structural component of literally every cell membrane in your body. It provides fluidity, stability, but it goes way beyond just structure.
And that's where it gets really fascinating.
Yeah.
Cholesterol is the precursor, the sort of raw material, for substances we cannot function without.
Like what?
Well, we're talking about essential steroid hormones. Cortisol for stress, estrogen, testosterone. And you also need it to make vitamin D and the bile acids that help you digest fat.
So the problem isn't that cholesterol exists. It's about how much there is and where it's going. The whole health crisis is really about its transport system breaking down.
Right, a condition we call hypercholesterolemia.
So our mission today in this deep dive is to get past those simple good versus bad labels.
Absolutely. We need to look at the actual physiological machinery, the genetics, the metabolism, how it all works, to understand why it's called the silent killer.
And then look at the really powerful modern ways we have to manage it.
Exactly.
Okay, so let's unpack that. If it's so important, where does most of it even come from? And how is that whole system supposed to stay in balance?
The first thing to know is that we have to start internally. The vast majority of the cholesterol in your body, something like 70 to 80%, is made right inside your liver.
So it's endogenous production.
Correct. And is all regulated by this one key enzyme called HMG-CoA reductase.
Now, I've heard that term before, usually when people talk about medications. What's so special about this specific enzyme?
It's what we call the rate-limiting step. Think of it like the main valve on a pipeline. When your body needs more cholesterol, the enzyme speeds up.
And when it has enough?
It's supposed to slow down. That's called feedback inhibition. The problem is, for a lot of people, that feedback loop is broken. The liver just keeps churning out cholesterol no matter what.
That explains why the whole diet debate is so confusing, because that other 20 to 30% is from food.
Exogenous intake, yes.
Well, we've been told forever to avoid things like eggs. But if the liver's making 80% of it, why is there so much focus on diet? What's the real disconnect there?
That is a fantastic point. And the disconnect is all about confusing dietary cholesterol with the fats that make your liver produce more.
I see.
For most people, the cholesterol you eat in, say, an egg or some shellfish, has a pretty modest effect on the cholesterol levels in your blood.
So what's the real dietary villain that's telling our liver to go into overdrive?
It's the saturated fats. And even worse, the artificial trans fats you find in a lot of processed foods.
Why are they so bad?
Because they hit you with a double whammy when it comes to clearing lipids from your system.
A double whammy? How so?
So first, saturated fats directly signal the liver to produce more cholesterol. But second, and this is critical, they also mess with the LDL receptors on the surface of your liver cells.
The receptors that are supposed to pull the cholesterol out of the blood?
Exactly. If the receptors aren't working right, the liver can't do its job as a vacuum cleaner. So you get more production and less clearance. It's the worst of both worlds.
Okay, now let's get to transport. Cholesterol is waxy. It can't just float around in the blood. It has to be packaged up.
And that's the job of the lipoproteins. They're basically little transport bubbles. The two we care most about clinically are low-density lipoprotein, LDL, and high-density lipoprotein, HDL.
And we all know LDL as the quote-unquote bad cholesterol. What's its job?
LDL's role is to deliver cholesterol from the liver out to the tissues that need it for repairs or making hormones. But when you have too much LDL, the particles can start to seep into the artery walls.
They get stuck.
They get stuck, and they trigger an inflammatory response. And that inflammation is really the first step towards atherosclerosis, the buildup of plaque. High LDL is directly causative.
Now, contrast that with HDL, the good cholesterol.
HDL is the protector. It does what we call reverse cholesterol transport. It's the cleanup crew.
So it goes in the opposite direction.
Precisely. It scavenges excess cholesterol from the artery walls and brings it back to the liver to be recycled or removed from the body. That's why high HDL is protective.
So if the system is designed for this balance, what throws it all off? We know diet is a factor, but what about genetics? You hear about that being a huge, unavoidable part of the equation.
Genetics can play a much bigger role than people think, sometimes completely independent of lifestyle. The most dramatic example is a condition called familial hypercholesterolemia, FH for short.
And that's an autosomal dominant disorder, isn't it?
Yes, and it's surprisingly common. It affects about 1 in 250 people. It's basically a genetic time bomb.
How does it work?
It's caused by a mutation in the gene for the LDL receptor. So because that receptor is faulty from birth, the liver just can't clear LDL properly. These individuals have profoundly high LDL levels, often over 190 right from day one.
Which means they're accumulating damage for decades without knowing it. It explains that high risk of, very early heart attacks. A 20-year-old could have the arteries of a 60-year-old.
That's exactly right, and it's why screening for FH is so critical. But beyond those primary genetic causes, you have the secondary causes.
The ones tied to other conditions.
Right, especially complex metabolic conditions.
Yeah.
The most common one we see now is the profile that comes with type 2 diabetes and insulin resistance.
That's a huge driver, I imagine.
A major one. Insulin resistance doesn't just mess with your blood sugar, it totally rewires your lipid metabolism.
Yeah.
You get this really dangerous triad: high triglycerides, low protective HDL, and an increase in these particularly nasty little things called small, dense LDL particles.
What's so bad about small, dense LDL compared to the regular, larger LDL?
They're just far more dangerous. Because they're smaller, they can wiggle their way into the artery lining much more easily. They're also more likely to become oxidized.
And once they're oxidized?
They become highly inflammatory. They're basically a magnet for your immune cells, the macrophages, which gobble them up and turn into what we call foam cells. And foam cells are the very first building blocks of plaque.
And what other conditions should we be aware of?
Hypothyroidism is a big one. A slow thyroid slows down your whole metabolism, including the liver's ability to clear LDL. We also see strong links with significant abdominal obesity, chronic kidney disease, and even some medications like corticosteroids. It's almost never just one thing.
The mechanisms are obviously complex, but I think what's truly frightening is the lack of warning signs. That's why it gets called the silent killer.
The silence is the whole problem, and I have to stress this. High cholesterol causes zero direct symptoms.
None at all.
None. You do not feel high LDL. There's no headache, no fatigue, no dizziness that's related to the number itself. The damage just quietly builds up over years, even decades.
So the only way to know for sure is a routine blood test, a lipid panel. But in very severe cases, often the genetic ones, the body can sometimes give off some visual clues.
Yes, these are really cholesterol deposits showing up in strange places. The most common one is something called Xanthelasma.
And what does that look like?
They're these soft, yellowish plaques of cholesterol that build up around the eyelids, usually near the inner corner of the eye.
If a doctor sees that, it's an immediate red flag.
Absolutely. It warrants a full lipid workup right away.
Right.
Now, even more specific to a condition like FH are tendinxanthomas.
Okay.
These are hard, lumpy swellings you can actually feel in the tendons, most often the Achilles tendon or on the knuckles. Finding those is almost a physical diagnosis of familial hypercholesterolemia.
And what about the ring in the eye?
That's the corneal arcus, a white or grayish ring of lipid that forms in the cornea. It's pretty common in older people, which is fine.
Yeah.
But if you see it in someone under 45, that is a huge red flag for a major lipid disorder.
So if the condition itself is silent, the terrible truth is that the symptoms are actually the catastrophic events that happen when the disease finally reaches a crisis point.
The symptoms are the clinical events. You're talking about coronary artery disease where plaque buildup leads to angina, that's chest pain when you exert yourself, or a full-blown heart attack when a plaque suddenly ruptures.
And the damage isn't just limited to the heart.
Not at all. Plaque in the carotid arteries in your neck can cause a TIA, a mini stroke, or a full stroke. And if it's in your legs, that's peripheral artery disease or PAD, which causes excruciating pain when you walk.
The consequences really highlight why treatment has to be so robust. So let's start with the foundation, therapeutic lifestyle changes, or TLC.
TLC is absolutely the bedrock, especially diet. The goal is to slash your intake of saturated and trans fats while really ramping up your soluble fiber.
How does soluble fiber, the stuff in oats or beans, actually help? What's the mechanism?
It's quite clever. Soluble fiber binds to bile acids in your gut. Your liver makes those bile acids out of cholesterol. So when the fiber carries the bile acids out of your body,
the liver has to pull more cholesterol from the blood to make new ones.
Exactly. It's a direct way to lower your circulating LDL. And of course, you want to replace bad fats with healthy, unsaturated ones from things like olive oil and fish.
But when lifestyle isn't enough, pharmacology becomes essential, especially for high-risk people. And the cornerstone of that is always statins.
Absolutely. We mentioned that HMG-CoA reductase enzyme earlier.
Right, the main valve.
Well, statins are HMG-CoA reductase inhibitors. They effectively jam that valve shut, which dramatically slows down the liver's internal cholesterol production. The liver then senses a cholesterol shortage.
Which makes it upregulate those LDL receptors we talked about.
It forces the liver to put more of those vacuum cleaners on its surface, and it starts pulling massive amounts of LDL out of the blood. Statins are proven to reduce heart attacks and strokes.
Now, for patients who need more help, or maybe can't tolerate a high dose of a statin, we often see another drug called ezetimibe.
Ezetimibe works differently. It works in the small intestine and blocks the absorption of cholesterol right there. It's a great add-on therapy.
And then there's the cutting-edge stuff that has really been a game changer. The PCSK9 inhibitors.
This is where the science gets really, really cool. There's a protein in your body called PCSK9. Its job is to find an LDL receptor and mark it for destruction after it's done its job.
So it's basically forcing the liver to throw away its own vacuum cleaners.
That's a perfect analogy. So what these injectable drugs do is block the PCSK9 protein.
So you're saving the receptor.
You're saving the receptor. You're extending its lifespan. Instead of being destroyed, it gets recycled back to the liver surface where it can grab more and more LDL. These drugs can drop LDL by over 50%. They're incredible for high-risk patients.
What about some of the older agents like fibrates or niacin? Are they still used?
They are, but for different things. Fibrates and niacin are mostly used for managing very high triglycerides and sometimes for raising low HDL. They're not first line for LDL, but they're important tools, especially for the lipid profile you see in diabetes.
And treatment isn't just about hitting some generic normal number. It's all about a specific target based on that person's individual risk.
That's right. If you're low risk, the target is pretty modest. But for someone who's already had a heart attack, a very high-risk patient, the goal is incredibly aggressive. We're talking an LDL less than 55 milligrams per deciliter.
Wow, that's low.
It has to be. At that point, the goal isn't just to stop the plaque from getting worse. It's to try and stabilize it, maybe even get some regression. You're fighting decades of silent damage.
The sheer complexity of it all, that balance between genetics and lifestyle, it really demands this kind of robust, personalized approach.
It does. And because this is such a profoundly asymptomatic condition, the single most powerful tool you have for your own cardiovascular health is proactive, routine screening. You can't manage a risk you don't even know you have.
Which raises a really important question for all of us to think about. If a patient who has already had a heart attack needs an extremely aggressive LDL target, like under 55, to mitigate the damage that's built up over decades, what does our deep understanding of this risk and the availability of these powerful drugs imply about the true ideal LDL level that the general population should try to maintain throughout their entire lifetime to prevent ever getting to that high risk point in the first place? It's something to contemplate